prescribed exercise and diet. I'm like, are you?
What?
In
Where have you been?
2037,
No
exercise will be suggested as a means to health.
So anyway, my tired for a moment. I can't stand those pills.
I think it really
They drive me
depends. I
nuts.
think it depends on if you're treating diabetes with an old drug like a sulfonylurea.
You guys
That's
pull
just-
your mics in so I can
That's
do
just
sound
treating
check
the
while-
sugar, but it's not
You can do
treating the
sound
underlying
checking.
cause.
Yeah.
Just keep talking.
Okay, so your point is that
roll.
we are utilizing treatments to treat a condition, and it's either not working great or it's working okay, but we're not changing it because they're not getting any worse and maybe things are under control. And we're not looking further into more up-to-date or newer ideas of treatment.
I would also say I think that part of the comment as far as is it making you sicker? What the hell? I saw a commercial or some shit for Vyleesi, something like that. Does that sound right?
Uh-huh.
What is it?
Yeah. And one of the, like, rattle off all these side effects. I thought peptides had like side effects or concerned. Oh, could cause ongoing muscle spasm that will persist for life and never go away and cause this. I'm like, which of course then leads you to treat the muscle spasm with your new. And this is the mentality of why medicine makes you sicker. You start treating each medication. I see this in the ER all the time. Fucking 80 meds.
Yeah.
You're treating the side effect with this. You're treating that side effect with that medication. All of a sudden, you're like, what the hell are you on anything for? So that I think is where people come into the idea of modern medications are in fact making you sicker because we keep treating the medication side effect with the next medication.
Isn't Vyleesi that med for
I didn't know what it was for. I just saw the damn commercial.
for libido?
Was it that one? I don't
think
remember.
so. Have to take a look.
I think so as well. But just the running list of all the problems with this and the side effects and this. I'm like, okay.
What if
FDA, could I finish with that one? Right. It's the first and only, Vyleesi is the first and only FDA approved as needed treatment for low sex drive associated with a hypoactive low sexual disorder desire in certain women who have not gone through menopause.
But that's not true. What about PD-141?
The other thing is that it was actually, it's not really, you have to be very cautious about alcohol intake. And I thought, okay, well, you're going to take something to increase your libido, which can't have any alcohol with it.
Right.
I don't think this is going to fly. And clearly I have, because it's been around with years, and we're still asking what it is. Do not use Vyleesi if you have high blood pressure that's not controlled or known heart disease.
Does a
Clinically proven
Campari
to
spritz
increase
count
your
as
interest in
alcohol?
sex?
What's
What do you say?
I said, does a Campari spritz count as alcohol?
It is interesting how it is required for all of these side effects to be listed to patients on this ad with the position that Dennis was suggesting for you when we were last sitting here together, that you could be an auctioneer.
Yeah.
And so I think there's a place for you on the television of counting lists of
Yeah, that job's made for
Probably
you.
pays well.
Perfect. Boy, I don't really go over that long list of side effects with people. I just
No.
give them the big hitters. Like with statins, I'll say muscle aches and maybe muscle weakness, but I'm not going to talk about the stuff that's less than 1% likely
Right.
to happen because they're going to get scared. They're not going to take the medication.
Totally agree with you.
Yeah.
Wasn't the point I was making. The question is, and the point I'm making is, I bet, and I'll own this, most of us don't know the 3,000 random less than 0.5% side effects that can occur. And so
Right.
we see the patient thinking they've got a new issue, and we're treating a side effect. We didn't even realize it was a side effect of the medication they're on.
Yeah.
Oh, they
But
have,
you- well,
one
what's
of the
the-
rare ones who have high blood pressure. One of
Yeah.
the rare ones that can cause high cholesterol. And one of the rare ones that can cause chronic migraine. Okay, you have migraine now. Let's put you on this.
Or was that just an error in the study?
Sure.
Such a low number of patients getting that side effect, potential side effect.
But I'm saying
Yeah,
in the
but-
context of this particular podcast is all.
The other good thing about them just checking online is they're gonna realize all of the side effects for themselves, and they'll come in and tell you.
This is true.
So
Yeah.
it's very little that's without any risk whatsoever or any side effect.
No pain, no gain.
The question today is, are we making patients sicker by giving them medication, or is modern medicine making them sicker? I think it's very complicated because there are so many side effects associated with medications, and they're very low incidence, so we don't really easily recognize them as such. And if patients do have side effects, they should contact their physician right away, and if they either can't get in touch with them, they should just stop the medication unless they've been warned against stopping it.
Right.
Which is another problem.
When I look at whether or not to prescribe a medication, it's risk and benefit. For example,
Yeah.
if somebody's at high risk for a coronary event, a heart attack, for example, the risk to a patient of using a statin is very low. They might have bothersome side effects, but not likely to threaten their life. And if they have muscle ache and they stop it, within 2 weeks, probably the muscle aches are gone. But if I don't at least suggest the statin or some other drug, then they're going to lose out on that protection that I'm offering them.
Yeah.
But I think the gap here from what we're discussing versus what the average patient or consumer might be asking about is, I think the Wegovy is a perfect example. You have a medication that can cause weight loss. Fantastic, in theory. But it can also cause muscle loss, which leads to bone density loss, which can cause osteoporosis and osteopenia, which we put on a new medication for to reverse the osteoporosis or osteopenia, which then has its own list of side effects we have to treat. And I think this is where people start getting into the idea of this pharmaceutical flywheel and modern medicine flywheel of, we just gave them one drug to give them a new disease, to treat one disease and create another one that would then treat with another drug. And this is where, again, when it comes to certain medications, absolutely they're relevant, right? Nobody's sitting here arguing you shouldn't be on a statin for XYZ events or you shouldn't be on chemotherapy.
Some people might argue.
I know, but fine. Anyway, that aside, I think the point being, the question is, are we cognizant enough of some of the medications that we use and effectively, we'll call them side effects, but diseases that they're inducing that then get treated with other medications or treatments? And I think that there's a lot of pushback from patients more and more of they don't trust the medications. They don't trust what we're using traditionally in terms of,
That's true.
hey, what is this actually going to do to me? And what did you put me on? And do I need to be on this? And they're asking that because they're looking around saying, I've got my dad who's on 18 pills a day. What the hell? Why? And you can't even tell me what they are. You show up in the emergency department and you give me a list like this. Could it be a side effect? Sure.
Strangely, though, ironically, some people don't mind being on 36 supplement pills a day. And when I suggest a statin, I get the look. There's a pause in conversation, and I know what's going to come next.
Yeah.
But to your point, you brought up the point about Wegovy. We all in this room have the ability to take the time to discuss. You have to do resistance training. You have to take protein. You have to exercise. We have the time that a lot of other practitioners working for corporate medicine don't. They're getting 15 or 20 minutes. They're rushing through 4 different problems in that time.
Sure.
Because the patient wants their money's worth and their time's worth. They're under the gun to do what they have to do in that small space of time, whereas we can counsel them. We can give them our literature and say, this is what you have to do to avoid muscle loss, bone loss, and so on.
Yep.
We're lucky that way.
Sure.
The irrationality of patients, though, is always surprising. Or I shouldn't say, frequently surprising, as how illogical they are when it comes to medications, that somebody has given this a bad name, whether it's estrogen or it's Wegovy or it's just, this is a really low chance and this is the positive. Okay? Just be sensible.
Yeah, I think for patients sometimes that worry, it's an emotional worry, whereas we have more of a measured worry. We have the years of experience using these drugs or similar drugs, and we may think to ourselves, okay, the benefit's going to be here, up here, and the risk might be down here, so I feel comfortable giving it to you and monitoring that. That makes logical sense to us, but to a patient that has this emotional worry, maybe the logic doesn't play.
Do you remember the times when there were a few early cases with the use of Fosamax, that there was mandibular necrosis?
Never seen it.
No, but it sounds gruesome and you wouldn't want anybody to have it. This patient she had severe osteoporosis, older, absolutely at risk of a spontaneous fracture. And I recommended to her that she start on Fosamax. This was in the early days when that was pretty much the only medication there for that purpose. And she refused to take it because of the risk of mandibular necrosis that occurred in 0.1% of the patients that were supplied, because she'd had some expensive dental work done and she didn't want to damage any of that. And here she was faced with osteoporosis that was life-threatening
Sure.
versus her low risk of mandibular necrosis because it had been reported.
That's your patient's perception of which is more awful.
Yeah.
To us,
Right.
that osteoporotic fracture and the risk of death in the first year following the fracture,
Uh-huh.
that's the awful part.
Yeah.
But they're not seeing it that way.
Yeah. They might have spent their money for their dental work for nothing. If they died, it wouldn't matter.
Very true. I think there's a bit of an
Probably
elephant in
got
the
that.
room in the past few years that is pertinent here in terms of COVID vaccine, CDC recommendations, mask mandates, double mask mandates, now no masks, now give it to 6 months old, don't give it to 6 months old. What's the mortality rate? Was it really COVID? Which the COVID kind of aspect of it aside, it has completely destroyed faith from most patients in terms of what's really coming out of the medical profession. And it doesn't matter what kind of doctor you are, what you practice, there's an assumed kind of tie-in to these organizations, for lack of a better term, that we've otherwise, as a field, heralded for the past, 50, 60, 70 years in terms of, hey, FDA, gold standard, CDC, gold standard, you can trust them. And that has been absolutely destroyed and debunked, unfortunately.
It has.
And we are all guilty by association no matter what. And as a
Right.
result of that, they're like, what else are you giving me?
Yeah.
You know, that you're not telling me. What does the mRNA vaccine really do? Was just the tip of the iceberg. Now it's what does everything actually do that you're not telling us? And it's a valid question. And part of why there's this thought of, is medicine making me worse? Is it causing these problems for me?
Mhm.
And to your earlier point, as far as gross overreaction, the J&J vaccine was 1 in 6 million women had a risk of DVT, not developed, if I remember correctly, risk of developing a DVT, which is some like astronomical amount. Again, I might have it wrong with stats, but it was something in the millions. And then not even above the knee DVT that's actually risky, because that was a even smaller percentage, or DVT becoming PE, a smaller percentage. And they pulled the vaccine. I'm like,
Yeah.
it doesn't inspire a lot of confidence when you start zooming out and questioning what is the thought process here.
My experience with patients, if they have gotten the COVID vaccine with symptoms, is usually, we all know what the horrible things can be, but the common things are what you can get with a flu vaccine, which is just an immune reaction. You feel flu-like, you're tired, you feel flushed, you're just wiped out.
Yeah.
Sure, you can get pleurisy, which is an inflammation of the wrapping of the heart called the pericardium. You can get pericarditis, or pleurisy, which is an inflammation of the lining, the outer lining of the lung. Not very common, but has been reported. Is that true? I
Yeah.
think so.
Yeah.
Yeah,
Similar to what you can get from COVID itself.
for sure.
I haven't really had any patients complain of that or got seen for that, but
I think it's more so the question of, okay, but the COVID vaccine was also linked to myocarditis in young, healthy individuals. So why did they get the vaccine? They had such a low risk of death. Why were we giving it to children and advocating for it who had, after, if they were clear of the kind of RSV window with respect to bronchospasm, they were pretty much clear of the COVID mortality window as well. But we gave it to them anyways, an mRNA vaccine, and with 0 clinical trials done on that age group. And we all know this is true. And again, that loss of trust, an understandable loss of trust, has hit us all in terms of what else are you giving us that we don't understand. And take it one final step further. The majority of medications, I don't know if it's a majority, but many medications we use off-label in ways that they weren't initially used for. And that inevitably begs the question of what is the side effect profile when you're using it off-label? We assume it's the same side effect profile that it was in the prescribed patient population, but that's probably not true. So I'm just, again, the consumer hat, so to speak, the patient hat of understandable doubt around, are you making us sicker? Not intentionally, but potentially inadvertently by...
Yeah, but they treat
Right.
us like it's intentional.
Of course. It's a shoot the messenger
Yes,
mentality.
it's absolutely.
It's-
Yeah.
But that doesn't help the messenger.
Honestly, I would really, on another day, because I'm done with podcasts today, although we haven't finished yet. No, on another day, I'd really like to have a discussion about COVID and how we treated it and how we should treat it going forward, or a similar situation in the future because the society is split and along non-scientific grounds.
Yes. In both directions, I would say.
Yeah.
Yeah.
And so I think that would be fun to talk about for future reference.
I think the whole COVID thing is messy, period, because you can't predict on an individual level what's going to happen to any given patient. You were talking about younger people and how they're less likely to have severe complications. And that's true on a population level, but not an individual level.
But the recommendations were done on a population level, which is exactly the same problem.
That was a
Blanket
pretty scary
recommendations.
time in 2020
Well,
when
people are
people were
dying
going
like
on ventilators.
flies.
Yeah. It was an emergency.
Sure.
And particularly if you're in your 70s and
Right.
got some underlying medical
Right.
issues.
But even if you vaccinate and treat, people can still get sick. I had a
Yes.
patient that I was asked to do house calls on because she couldn't get out of bed for months. She couldn't come to my office. She was in Italy with her husband,
Not the one I sent.
and she, what's that?
Not the one I sent. Okay, good.
Oh, no. She and her husband got COVID-19 infection, and thankfully they had Paxlovid. They had been vaccinated multiple times. So they were treated, and she felt better. 3 weeks later, she started to feel really poorly. Husband did fine. She developed post-COVID dysautonomia, which is an attack on your autonomic nervous system, the part of your nervous system that controls things you don't have to think about, such as eating, digestion, heart rate, blood pressure. And she had what was called hyperadrenergic POTS, which is where, it's a misnomer, but that's what they were calling it. When she would lift her head up, especially when standing up, instead of the usual POTS where your blood pressure tanks when you stand up against gravity, her pulse and blood pressure would surge. And when I saw her, she just lifting her head up 9 degrees from the bed, she got that surge in pulse and blood pressure. She had to go to the bathroom in the bed. She could not get out of that bed. And she did everything right. She did the vaccines. She was treated with Paxlovid right away.
Yeah.
And yet still had that because COVID can get into your nervous system. Pretty amazing case.
Yeah, absolutely.
But just illustrates how complex this is.
Yeah.
I don't think those here we go. I don't think those mRNA vaccines or medications are going to go away. There's a new one coming out, hopefully, if it passes through regulation that lowers lipoprotein little a by 85 to 99%.
Wow.
And that's mRNA technology. It's a mirror image of the mRNA strand that comes out of the cell nucleus for lipoprotein little a, and it just binds up to it and jams it up so it can't go through the ribosome. The protein manufacturing part of the cell can't make lipoprotein little a. I don't think they're going to go away.
No, they're not.
There is still a lot of fear about them, of course.
I think it's very well-founded fear in terms
Yeah.
of
It's new stuff.
it's new stuff. And I'm not going to put this on the podcast, but I'm going to say it out loud regardless. If I'm not mistaken, there were 30 plus years of attempts to develop mRNA treatments for cancer, and none of them ever cleared a phase 2 clinical trial. But we pushed an mRNA vaccine for healthy people out in less than 12 months. That is not kosher. Period.
It was an emergency, though. I remember that time,
Was it?
2020. I thought so.
Yes.
Was it for everyone
part
they
of the country
suggested
were you
it for?
in then?
No. Was it for everyone that they encouraged vaccine for? And this is where it gets into this very messy conversation.
We're doing hindsight now, so that's easier. Back then, I remember when I started to see people walking to supermarkets with a mask on.
Yes.
And I was looking around and I thought, what's going on? And then I saw people on ventilators,
Yep.
saw people dying. And I just think we didn't fully know the way forward yet. So I was happy to get that vaccine when I was
Yeah.
working for UCLA. I drove 3 hours round trip to get that.
I did actually similarly to get the vaccine.
I knew it
The
was
first
Neither
time.
by I had to drive that far.
I had a little concern about it, but number one, I had to get it. But
I had almost no concern about it. And that's, I was brought up in the time of polio and yellow fever and being fatal diseases and vaccinations that came into play to basically take it off the planet, almost. And so those were things that happened when I was a kid, but I was aware of it. A very good friend of mine's dad was one of the significant scientists involved with the yellow fever vaccine in South America. And so vaccines never worried me about the vaccine part of it. It's just I didn't want a needle if I didn't have it. Didn't have to do that. That was a worse concern than anything else. But the vaccine was going to become available here, and the cottage hospital was going to be controlling it with the help of the local government, whether it was the state or the township, I don't remember which. And the first people who were going to get treated were the first responders in the hospital, the people at most risk. And then a doc who hardly ever went in the hospital was third on the list. It was weeks down the road. I was also working in the Bay Area. And when they got the vaccine too, about the same time as they did down here, and I could get it with the next time they gave some shots. So one Saturday morning, I drove to Oakland to get a shot and turn around and go back. And there was no question in my mind that this is what I wanted to do. And I had no worries about it whatsoever. Maybe the no worry was stupid, but I was obviously on the risky member of the population, but otherwise in pretty good health. But I was worried about it. But I wasn't worried about getting the vaccine. I would get that as soon as I can. And I did it a couple of times after that as well. So I may not have lived to tell the story had I not been vaccinated. Right. I don't know. It's just there. So in retrospect, it was the right thing to do. Let's rephrase that. I was glad I did it. But we didn't know what we were dealing with. We didn't know how bad it was going to get because the vaccine was only just becoming available. We didn't know how well that was going to work. And it seemed to me like it worked pretty well.
Wow. I remember seeing people on ventilators on TV, and I thought, what's going to happen to me? I'm a healthcare provider. Am I going to get exposed? Am I going to be on a ventilator?
Yeah, absolutely.
I get your point about the fact that it was new. I was just happy to get it. Like you, I thought, okay, something bad could happen from this vaccine. It's brand new, but I was ready to take that risk, and I was obliged to take it anyway. Working for UCLA, right. I don't think I had a choice.
Yeah. Interest.
Please feel free not to come back to work if you don't get your vaccine.
Yes. Yep.
That's nothing new. Flu vaccines have always been mandated as well, so that's not exactly new for healthcare providers.
Okay. It's something that we, as physicians, should all be aware of as discussing risks and benefits for patients, and not get too pissed off when patients don't do what we suggest.
Yeah, I think it's just worth remembering or realizing that there's been a loss of trust for the entire medical industry.
I think,
we just gotta, whether we like it or not, we're part of that problem, so to speak, in terms of we're a face of that loss of trust.
Yeah.
Whether or not to take a certain medication, it's a discussion. Nobody has to take a medication. There's always going to be that risk and benefit ratio. Just try and pick carefully and educate.
Yep.
Yeah, absolutely. This is another problem we should solve. Or anytime. I like that. Thank you. Thanks, guys.
All right.
Interesting.
Thank you.
Thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening.